Good morning, everyone. Welcome to this morning's hearing of the House Committee on Health. We are present in room 329, and it is Wednesday, February 11th, 9 a.m. I want to welcome all of you for being here this morning. Just some housekeeping reminders. Number one, you'll notice that unlike previous years here at the Capitol, there are no microphones in the room. So we ask that when you testify, you come up to the podium and speak in a clear voice. The mics will pick you up. They're the green lighted devices in the ceiling, and they're very good at picking up voices. But we do ask that you speak clearly. And for the audience members who are listening rapidly to the testifiers, remember that the mics can pick you up as well. So please try and keep your comments to whispers. Also, for those on Zoom, we ask that you keep yourselves muted until you're queued up, and ask that you not show any trademark items because we are being televised to a worldwide audience on YouTube, and YouTube discourages that. Now we have many bills before us. So I ask the testifiers abide as well as they can to a 2-minute time limit in their testimony. That will make sure that we have time to hear all of you as well as leave time for questions. So first up, we have House Bill 1871 relating to establishing a maternal health monitoring pilot program. And we have the Department of Health.
Department stands on its testimony
Offering comments, okay. Let's see. Hawaii State Commission on Status of Women offering support. On Zoom, I believe we have the Hawaii affiliate of the American College of Nurse Midwives.
Aloha, thank you for this opportunity to provide oral testimony. We stand by our written testimony. I wanted to bring to the attention the work of the healthcare provider barrier to practice review task group. In the work of that group, they reviewed various previous existing legislative statutes where it was deemed appropriate to adopt provider neutral language. So for example, where a healthcare provider might have been utilized, it could be replaced by qualified healthcare provider. And the meaning of that would be any person with a current active license or certification issued under Title 19 or Title 25 whose scope of practice, as defined by any applicable law and rules adopted thereunder, authorizes the person to provide the healthcare services described in this chapter. As a legislative representative for the Hawaii affiliate of the American College of Nurse Midwives, we want to reiterate that midwives are some of the primary providers of care for prenatal and postpartum care, and we don't want to be excluded from a very valuable pilot such as this. So in our written testimony, we supplied a replaced definition of the healthcare provider, and including the the definition for the remote monitoring clinical care team, where it identifies nurse. We provide the suggestion that a qualified healthcare provider could also be in place. That would potentially expand access to this pilot project for all providers to engage and serve the Hawaiian people. Thank you.
Thank you very much. And for the record, your name, please?
Oh, I'm so sorry. Thank you. My name is Margaret Reagan. I am
Okay,
a
thank you.
certified midwife and the legislative contact for ACNM.
Thank you. Next on Zoom, I believe we have Christine Perez, Maternal Health Clinical Lead. Please proceed.
Good morning. Thank you for having me. My name is Christine Perez. I have a PhD in public health and a nurse for 30 years in maternal child health. I also have 30-week preterm and have lived a long time implications, including asthma as of today. The March Times reports 25% of counties in Hawaii have a high burden of preterm births and chronic health conditions. Chronic health conditions increase the rate of preterm birth by 34%. Obesity, hypertension, and diabetes are all leading contributors to preterm deliveries. They also increase the risk of maternal mortality, stillbirths, C-sections, postpartum hospital readmissions. Remote monitoring has been shown in studies to reduce C-sections, decrease ICU length stays, and improve adherence to medication, as well as it increases postpartum visitation guidelines, which are typically only met 40% of the time due to a lot of access barriers to care. The Center of Healthcare Quality and Payment Reform January 2026 reported that moms in Hawaii can average time of travel to 68 minutes to care. Remote monitoring provides an additional avenue to access care, meeting people where they are. Utilizing cellular devices also helps eliminate any Wi-Fi shortages, issues, or data plans. Philips has partnered with Georgia to implement a similar pilot, and I can tell you some of the main things that have been a benefit of the program is really maternal empowerment, where they understand their diagnosis better, what target blood pressure or glucose they need to have, urgent maternal warning signs, the need for low dose aspirin. There's also someone at the other end monitoring the measurements that they have, whether it's glucose or blood pressure 24/7, and notifying them and talking with them and to understand if they're having any urgent signs that need emergent care and managing that condition. For all of these reasons, Philips respectfully urges the passage of HB 1817. Thank you so
Thank you.
much.
Let's see, we also have a written testimony in support from the March of Dimes and an organization called AdvaMed. That's all the testifiers I have listed. Anyone else wishing to testify in this measure? Here or on Zoom? Seeing none, members, any questions? Seeing none, let's move on to the next bill, which is House Bill 1977, requiring Department of Health to establish a maternal and infant health information mobile app. And first up, the Department of Health. Okay. Let's see, Hawaii State Commission on Status of Women in Support, American College of Nurse Midwives on Zoom.
Aloha. Again, my name is Margaret Reagan. I am testifying on behalf of the Hawaii affiliate of the American College of Nurse Midwives. We stand by our written testimony. We are requesting inclusion of the organizations through which people will be able to access resources. The American College of Nurse Midwives has online resources that and position statements for over 63 different conditions related to women's health and pregnancy. Some of the other organizations do not have all of these resources actually publicly available if you are not a member, but ACNM does provide those. So we hope to be included within other organizations such as CDC, NIH, ACOG, AMA, and AAP. Thank you.
Thank you. We have Manny here from Philips on Zoom.
Yeah, hi. Good morning, Chair Takayama, Vice Chair, and members of the committee. My name is Manny here, and I'm here on behalf of Philips Healthcare in support of HB 1977. Philips has a long history in maternal and infant health from our hospital-based ultrasound and fetal monitoring technology, all the way to Pregnancy Plus, such an app, as in that's most widely used in terms of the pregnancy apps as far as it goes globally. So nearly 4,000 expecting families in Hawaii use our app. They use that in 2025. As you all know, when someone finds out that they are pregnant today, one of the first things they do is that reach out for the phone. And we believe that HB 1977 recognizes that reality. And this bill, as you know, allows the Department of Health to procure a maternal and infant health mobile application for Medicaid-eligible prenatal, pregnant, and postpartum individuals and their families. Other states are already leveraging similar pregnancy apps to better connect their Medicaid families to services, the state services, states including Michigan, Arkansas, New York. And these states have used mobile platform to increase awareness of their home visiting, nutrition programs, and other maternal health resources. So for example, Michigan leveraged a Philips pregnancy app to promote awareness of the state-based programs like the home visiting. The app connected with 3,200 Michiganders who are on Medicaid. Information about the state programs was seen on the app over 2.25 million times, and over 3,000 moms were referred to home visiting. So, and through the service from the app, about 50% of the users said that they learned more programs about the state programs from the app. So Hawaii already invests in important maternal health programs. The challenge is often with awareness and navigation. A mobile app can serve as a trusted centralized entry point, helping family understand their benefits, connect to the state resources, and stay engaged throughout the pregnancy and postpartum. So for these reasons, Phillips respectfully urges the passage of HB 1977. Thank you very much.
Thank you, thank you. Let's see, we have a written testimony from the March of Dimes expressing support. Anyone I missed? Anyone else wishing to testify on HB 1977? Seeing none, members, any questions?
Chair, I have a question.
Representative Hutch.
Thank you, Chair. For the Department of Health. Thank you for your testimony. I do have a question in terms of implementation. If this bill were to pass, how much time would the department need in order to implement what this bill proposes?
Thank you for the question. Hi, I'm Matt Shim. I'm Chief of Maternal Child Health Program, Family Health Services Division. Right now, we have not discussed folks on how we could actually implement this. Timeline. If I know my other timelines, to implement software, data security. Also, we need to have agreements with MedQuest for the Medicaid population. It may take over.
Thank you. Chair, no further questions.
Okay.
Thank you.
Any other questions? Seeing none, thank you very much. Let's move on to the next bill, which is HB 1858, leading to certificate of fetal deaths. And first up, we have the Department of Health.
Good morning, Chair, Vice Chair, members of the committee. Health. The department supports HB 1858 with amendments. This is a fairly consequential measure that will allow greater quantity and precision of data being collected on lives. We are unable to dig as deeply as we would like into the upstream process of this, and this measure will allow that by aligning data collection methods to be consistent with national best practices. However, as currently drafted, this measure creates significant administrative barriers, and the department has recommended some amendments that will negotiate with stakeholders, and there appears to be consensus among stakeholders that is preferred. So we urge this measure move forward with our amendments, and I'm available for questions. Thank you.
Thank you. Let's see, we have written testimony in support from a number of organizations. Read some of them briefly. Hawaii State Commission on Status of Women, Hawaii Funeral and Cemetery Association, Hawaii Medical Association, Hawaii Pacific Health, Hawaii Women's Coalition. Let's see. On Zoom, I believe we have Dr. Joy Vink.
Good morning, everybody, and thank you, Chair Takayama and committee members for hearing this bill and your time. I am Joy Vink. I'm one of the high-risk OBGYNs over at Kapilani, so I deal with a lot of the complicated pregnancies here at the hospital. I actually grew up here, sort of a backstory. I moved home a couple of years ago, and here at Kapilani was actually very shocked to see our high rate of fetal death that was happening here at the hospital. When I looked into it, actually coming across this data from the CDC saying that Native Hawaiians and Pacific Islanders have the highest rate, one of the highest rates of fetal death across the US. And trying, as a clinician, obviously we want to help. And having a family that experiences this tragic loss of a stillbirth is very traumatic. It is has lifelong effects for the family as well as the mom, and lasting psychological effects. So as a clinician, we really want to help and trying to figure out how we can prevent the high rate of fetal death that we're seeing here. Unfortunately, when I actually looked into trying to figure out how we can help, a lot of that comes from the data. And unfortunately, at a state level, our data is not very good. And part of that, and it's multifactorial, but in being in charge of all of our fetal death reporting at Kapiolani here, as well as working with the DOH for the last year and going to all of our birthing facilities to understand the challenges that people are facing in terms of reporting fetal death and data collection, coming to find out that the reasons are multifactorial, but a big one is our current fetal death reporting statutes. Our current statutes are severely outdated. They do not align with current CDC recommendations of what we are supposed to be doing in terms of reporting fetal death. And that's part of the reason why we're facing such challenges in getting good data. So this bill is very timely. We have the attention of the DOH. We have actually national attention as well to really understand what is going on here in our state. The time is now to revise our fetal death reporting statute so that we align with CDC recommendations and do what we're supposed to do to actually get good data. And once we get good data on the clinician side, we can actually start to come up with meaningful interventions to hopefully help our families and our communities to prevent fetal death. So that's the purpose of this bill. I thank you so much for your time and support, hopefully. I'm available for any questions if you have any.
Thank you. Let's see, we have written testimony from from 12 other individuals in support. Anyone else wishing to testify on HB 1858? If not, members' questions? Seeing none, I do have a question for Dr. Vink. I gather the Department of Health is proposing to amend the bill by making physicians as well as APRNs responsible for issuing documentation of fetal deaths rather than the Department of Health. So just want to make sure that you're in agreement with the proposed amendment from Department of Health?
Yes, we are in agreement. We have talked extensively with the DOH and we fully agree with their new language.
Now, their language says that the physicians and nurses who certify the fetal death due to miscarriage may issue documentation of the fetal death. Do you have a problem if we change may to shall?
I'm sorry, it broke up. Can you repeat that?
The amendment that the Department of Health is proposing says that doctors and nurses may issue a certificate of death to the parents. I'm asking if you would be okay if we change the may issue to shall issue.
That's fine.
Okay.
I think part of that statute is focusing on less than 20 weeks. That language is for less than 20 weeks or less than 350 grams if we don't know the gestational age.
Yes. Yeah.
And that is optional reporting. So if a family, because a lot of the families are really struggling and they don't get any sort of documentation when they have a miscarriage, in order to help them with their closure and healing, if they would like us to submit this information, and give them a copy of the form that we submit, we'd be happy to do so.
Thank you.
And we definitely don't want it to be the DOH's responsibility. It'll be ours.
Thank you so much, Doctor.
Thank you so much.
Well, with that, let's move on to the next bill if there are no other questions. Oh, Chair Martin.
Yeah, sorry, again for
Dr. Vink.
Dr. Vink.
Sorry.
In sessions past, this body has learned that our, the data gathered was insufficient to give us a good understanding of what impact home births were having on our fetal deaths. Would this process described here change that in any way or give us any better data of a role played, with a delivery that was perhaps started at home and then was transferred to the hospital because things weren't working out?
There is data on the report that we fill out at the facilities of whether or not the birth was done at home or at the hospital. So there is a way to track that. There is actually motions now to actually form a fetal infant mortality review committee in the next year, hopefully, which we will then dive into much more detail about all the fetal deaths that are occurring here in the state. So that will also give us more information as well. But the starting point is this bill and trying to get our data better at a state level. And then obviously we will have a group of experts diving into more detail to understand all the different reasons why, and hopefully coming up with interventions to prevent this in the future.
Thank you, Chair.
Thank you very much. There are no other questions. Let's move on to the next bill, which is House Bill 1591, which expands the definitions of preceptor and volunteer-based clinical training to improve, receive income tax credits. First up, we have the Department of Health.
Good morning again, Laura Kim on behalf of the Department of Health. The department does support HB 1591, but prefers a very nearly identical measure, but one that is a little more expansive, which is HB 2206. And I'm available for questions. Thank you.
Thank you. State Department of Taxation, offering written comments and suggesting a couple changes which more clearly define a couple terms that are used in the bill. University of Hawaii in support. Hawaii State Center for Nursing. Good morning.
Aloha, kakahiaka, chairs, vice chairs, members of the committee. My name is Laura Rykar. I am the director of the Hawaii State Center for Nursing. I also have the pleasure of administering this program. I stand in support of my written testimony, and I also want to say that I also support the testimony provided by Department of Health. Thank you.
Okay, thank you very much. Hawaii Substance Abuse Coalition in support. On Zoom, I believe we have Tom Yamachika, Tax Foundation of Hawaii. Not present, okay. We have Queens Health Systems in support. Several other organizations in support on Zoom. Do we have the Hawaii affiliate of the American College of Nurse Midwives?
Yes. Ooh, sorry. Aloha. My name is Margaret Reagan. I'm speaking on behalf of the Hawaii affiliate of ACNM. Mahalo for this opportunity to provide additional testimony. We stand by our written testimony. We appreciate the work that has been done over the past 2 years. This bill was deferred from last year. As people working in the health field are well aware, there's very great barriers to securing clinical placements. Within the field of midwifery, it's additionally challenging because in the state of Hawaii, there are no institutions to obtain an advanced practice midwifery credential. So the majority of students who are from Hawaii will enroll in programs on the continent, and there are a variety that are hybrid programs available. The way that this bill is written, it excludes all midwifery preceptors, APRNs, and CMLMs. So those are certified midwives who are also advanced practice credentialed midwives. What we are suggesting is that if it is possible to add an additional provider, because the certified midwife also acts as a primary care provider, provides women's health care, reproductive health care, postpartum care, basically care from the time that a child would have their period to the end of their life. And but the way of the language of the bill, it's excluding this particular credential. And but the other part is that the only Hawaii-based students, so this would be for other professions as well. The only schools students attending schools, they have to have at least 50% from Hawaii attending their school. It seems very exclusive. If there was a way it could be amended to include Hawaii-based students who are enrolled, but they in a school in the continent, but the majority of their clinical training occurs in Hawaii under Hawaii preceptors, it could help grow our own.
Thank you, Ms.
you.
Reagan.
Thank you.
Hawaii Public Health Institute.
Aloha, Chair, Vice Chair, members of the committee. I'm Chris Coughlin from the Hawaii Public Health Institute. We support this bill. We're supporting all preceptor bills that are expanding this program. As you all know, there's a huge medical professional shortage in Hawaii. There was a report recently that showed that there are 833 full-time physicians in need. Hawaii County had a huge shortage. It's a big problem on the neighbor islands. According to recent data on Maui, or in Hawaii County, it would need to grow its supply of physicians by 43% to meet demand. This is a proven solution. There have been studies on this that show that since its implementation, when it's originally evaluated, there was a 77% increase in active preceptors, so this works. We're really excited to see social workers included in this program. There was a report from the UH Thompson School of Social Work and Public Health that showed the demand for healthcare social workers in Hawaii is going to increase by up to a quarter. Up to 25%, and the need for specifically mental health and substance abuse social workers is estimated to increase by about 22% over the next 10 years. So we're really excited to see them included as well. Thank you very much for moving this measure forward.
Thank you very much. Let's see, that's all the testifiers I have listed. Do I have, is there anyone else wishing to testify on this bill? Seeing none, members, questions? Seeing none, let's move on. Next bill up is House Bill 1574 relating to the healthcare education loan repayment program. And let's see, I have to note that we have written testimony and support from the governor. Next up, we have the State Health Planning and Development Agency, SHPTA, Dr. Lewin.
Morning, Chair, members. We support this and stand on our written testimony.
Thank you. See, we have Office of Hawaiian Affairs in support, Hawaii State Center for Nursing, Laura Reichert.
In support.
In support. HMSA, Waldenau.
Morning, Chair Takayama, Vice Chair Keokafu Biloy, members on behalf of HMSA. We appreciate the legislature's continued support of this very important program to help address our healthcare workforce shortage. So thank you, we stand in support.
Thank you. On Zoom, I believe we have the American College of Nurse Midwives.
Aloha, mahalo for the opportunity to testify. My name is Margaret Reagan, speaking on behalf of the American College of Nurse Midwives. We are in support of this bill. The concerns that we have is that although our members recognize the importance of workforce retention and the value of service to publicly insured populations, the concerns have been raised regarding a threshold of 30% of clients being recipients of MOC. And so we don't know how that could be adjusted. Post-graduation, midwives face challenges in securing employment. Though midwives have a scope of practice that allows them to practice in hospitals, clinics, in birth centers, and in the home, it is not always easy to secure that job, and yet we are hoping that more and more midwives will apply to remote programs, be able to find preceptors in Hawaii, and then to be able to work. They would not be eligible for this if they can't secure, if they go into private practice or they work for midwives that are within private practice. So if there is any way to accommodate, and this, I'm assuming this might be true across the field, across different types of credentials, where not all doctors or dentists take Medicaid clientele. So I can't, we haven't proposed an amendment suggestion, but we're just providing feedback that this could be prohibitive for expanding Hawaii-based providers.
Thank you very
Mahalo.
much. Thank you. Let's see, we have testimony in support from, let's see, a number of local healthcare associations, including the Hawaii Medical Association, Queens Health System, and Hawaii Pacific Health. Let's see, is there anyone I missed who wishes to testify on this bill? Seeing none, members, any questions? No questions, okay, let's move on. Next bill is House Bill 1575 relating to Parkinson's patient air transport, creating a feasibility committee to make recommendations in that regard. First up, Department of Health.
Good morning, Warren Kim, Department of Health. We appreciate the intent of this measure. At its heart, the solution to supporting individuals with movement disorders traveling inter-island for healthcare appointments is likely going to be a healthcare or health insurance or health benefit solution. That's generally not the kinds of programs that the Department of Health administers. So in lieu of that, we are recommending that any appropriations be redirected to dive into Parkinson's research in the state of Hawaii. We just don't really have a good sense when compared with some of the other jurisdictions on prevalence and incidence, and that we think that would be a better place to start. But we will participate in any community conversation that will improve the lives of Hawaii's residents. Thank you, and I'm available for questions.
Okay, thank you very much. On Zoom, I believe we have the Michael J. Fox Foundation.
Yes, good morning and thank you committee members. Special thank you to Chair Takayama for authoring this important bill. My name is Jared Giruso-Cloak with the Michael J. Fox Foundation for Parkinson's Research. MJFF is the world's largest nonprofit funder for Parkinson's research, having invested more than $2.5 billion globally to accelerate better treatments and ultimately a cure. I've submitted written testimony, which I stand by, but I want to briefly lift up one key point. For many people living with Parkinson's in Hawaii, access to movement disorder specialists requires inter-island travel. As the disease progresses, mobility challenges, costs, and logistics can make that travel difficult or even impossible, delaying care and worsening outcomes. This bill makes a thoughtful step towards addressing that barrier by examining practical solutions to help patients reach the care that they need. So we respectfully ask for your support. Thank you.
Thank you. Hawaii Parkinson Association, Glenn Higa. Hi, Glenn.
Morning, Chair Takayama. Good morning, Vice Chair Keoho Kapu-Liloy and members of the committee. Glenn Higa, I'm the president of the Hawaii Parkinson Association, representing the over 8,000 people with Parkinson's and their associated caregivers, families, and friends, and so forth. We are in strong support of HB 1575, which would form a committee to study the cost of transporting labor-island patients with Parkinson's disease by air to Oahu. I'm fortunate that I just live a few hours away from the only movement disorder clinic here on Oahu. But I'm not, there's a number of neighbor island people that do not have access to care as much as I do. And so that's why we really stand in support of this legislation to form the committee. Not only is it difficult to travel for many people with Parkinson's, it's also very expensive when you consider airfare, ground transportation, sometimes lodging if they need to stay overnight. And in addition, many people living with Parkinson's need to travel with a caregiver as well. So now you're doubling the cost of this. So we feel that the creation of a state administered fund may help offset transportation costs, provide access to care for all Hawaii residents living with Parkinson's. Addressing the Department of Health, that is true, we don't know the full scope of neighbor island care, and that's why this bill would help identify the number of people that this would help as well. So we urge you to support this legislation. Thank you.
Thank you. See, we have testimony from the Hawaii Disability Rights Center in support, as well as 2 individuals. Anyone else wishing to testify on House Bill 1575. Dr. Loom.
Good morning. Thank you, Chair, Vice Chair, members, Jack Lewin, Administrator of SHPTA. We didn't have time with our 120 bills that we wrote testimony on this week to comment here, but we would hope that in the future, this kind of service could be allowed at least to appear on the neighbor island counties so that people would have access in that fashion. It would be much less expensive and better for patients. That wasn't proposed at this point, and maybe it isn't possible, but that may be where we ought to look to the future. Thank you very much.
Thank you. And I think our committee accounts for about 70% of your testimony. But thank you for being here. Anyone else? If not, members, questions? Seeing none, let's move on. HB 1854 relating to certification of community behavioral health clinics. Department of Health.
Good morning, Chair, Vice Chair, members. I'm Courtney Matsu, Deputy Director of Behavioral Health Administration, Department of Health. We stand in support of this bill to certify and establish this office to certify and monitor community behavioral health clinics. The certification is necessary to allow the clinics to qualify for enhanced Medicaid reimbursements and thus promoting their financial sustainability. The CCBH model is in operations nationwide. There are many clinics out there. What it does is it really expands the access to behavioral health services to provide care for all ages, regardless of ability to pay or insurance. It provides comprehensive care that includes both mental health and substance use, crisis care, case management, and psychiatric rehabilitation. We feel that by establishing this office, it'll provide the department with the infrastructure that will be needed to support the expansion of this CCBHC model throughout the state. Thank you.
Thank you. On Zoom, I believe you have the Attorney General's office.
Present, Chair.
Oh, you're present.
Good morning, Chair, Vice Chair, and members of the committee. I'm Deputy Attorney General Michelle Exalda. Our department submitted written comments noting that the bill does not appear to explain how the special funds satisfy the requirements of HRS Section 37-52.3. We recommend adding a purpose section to the bill that explains how the special fund meets these requirements. I'm available for any questions. Thank you.
Thank you very much. See, we have testimony and support from the Department of Human Services as well as two individuals. Anyone else wishing to testify on this bill? If not, members, questions? I do have a question for the Department of Health, Dr. Matsu. Having noted the Attorney General's concerns about the creation of a special fund, I gather the concerns stem from the fact that when we create a special fund, it's usually with the intention that the special fund be self-containing. The amount that you're requesting to start up is $800,000. Do you expect that the revenues to be deposited into the special fund would make it self-sustaining?
So the amount requested was to support the various positions for the office primarily. The special fund was requested in the event that we were able to have admin fees for the application and when the clinics needs recertification for those purposes, and primarily to support the operating cost of sending our team out to do audits for the certification and recertification, so the travel to the inner islands.
How many such clinics are there right now?
Currently, we have two clinics on Maui that are operating like a CCBHC. They're not yet certified because the state needs to apply to become a demonstration state with CMS. And with that designation, they can then start certifying the clinics.
Right. Thank you very much. I just note that I think the substance and intent of the bill would be still carried out without the inclusion of a special fund. So just
Thank
commenting
you.
on you.
I also wanted to make a point about our amendment. We did amend it to change the language from populated island to populated county, mainly to address that we wouldn't be able to provide robust services to Niihau. But if we did, if that amendment did carry forward, we wanted to call attention to page 5, line 5, that we would need to change the total number of members to 9, from 11 to 9.
Okay, thank you very much.
Thank you.
Let's see, there being no other questions, let's move on to the next bill, which is House Bill 1855. And it relates to establishing the Hawaii Violent Death Reporting System. First up, we have Colonel Rob Swanson.
Morning, Chair, Vice Chair, Representatives. Colonel Rob Swanson, United States Air Force retired. I'm a military veteran. I run the Governor's Challenge Task Force for Suicide Prevention. I run a DoD Veteran Suicide Prevention Program called Fight for Each Other, and I'm a member of the Prevent Suicide Hawaii Task Force. I'm here to testify in support of Bill 1855, and the only thing I might change is instead of establishing, I would say reestablishing, because we had a Hawaii Violent Death Reporting System. It was terminated on the 25th of September 2025, in part due to lack of funding, etc. It is a critical data source. Any of our efforts in suicide prevention have to be data informed. We have to know what the causes are so we can go after them. The Hawaii Violent Death Reporting System feeds directly into the National Violent Death Reporting System. It is critical for ongoing efforts. We have a 2-year effort where we're standing up a suicide mortality review. The Department of Education is using this data to combat school violence and suicides in school, with the highest growing demographic in suicide in the state of Hawaii. The Violent Death Reporting System includes additional things that are not in the data sets that are being proposed by the Department of Health, to include the circumstances of death, which they've derived from various sources, methods. Ligature is the #1 cause. Suicide is the #2 means of violent deaths in the state of Hawaii. This is just, it's a very important thing. Location, and then various populations, whether it was veterans or at-risk communities, etc. I have submitted written testimony in addition to the words that I have. Thank you for your time, and I'm a fierce advocate of this capability.
Thank you very much. Let's see, we have written comments from the Office of Information Practices, Department of Health.
Good morning, Chair, Vice Chair, committee members. Thank you for the opportunity to submit comments on this measure. So we stand on our written comments. I do want to just add to a little context that the current administration has caused extreme chaos and turmoil when it comes to federal funds and funding, specifically CDC funds. This unfortunately was a result of that, and there is a currently we had to negotiate with the CDC reestablishing our agreement in terms. That was accomplished by December of 2025. As a result of this vulnerability, the department did recognize that we had an opportunity to improve and become self-reliant instead of reliant on the federal government systems. We issued a HIPRO and have a contractor currently working on integrating all of the CDC violent death registry data points into our state registry system, and believe that current statutes already exist and support this measure. And I stand on our written testimony. Thank you.
Thank you. By the way, I'm sorry, did you identify yourself?
Sorry, Garrett Hall, Chief of EMS and Emergency Medical Services and Injury Prevention for the Department of Health. Thank you.
Mr. Hall, thank you. Let's see, Mako Arai.
Aloha. My name is Mako Arai. I'm a concerned former abstractor for the Hawaii Violent Death Reporting System, and I'm testifying in support of the bill. One point I raised in my written testimony is to hold the agency that manages the Hawaii Violent Death Reporting System accountable for their decisions and actions. The Center for Disease Control and Prevention manages the National Violent Death Reporting System. All the 50 states, District of Columbia, and territory participate in this program, as does Hawaii. To control the quality of the data, there are many rules, regulations, and requirements and standards that each participating system needs to meet. Anything outside of that, as the Department of Health stated in their testimony, would not be constituted as the Hawaii Violent Death Reporting System as it's designed. And the future plans that the DOH proposed, those are future plans. In the meantime, data abstraction and collection is on pause, which is detrimental to the data system such as Hawaii Violent Death Reporting System. Colonel Swanson stated suicide is the second leading cause of fatal injuries in Hawaii. The trauma system the DOH has does not collect information on ligature or hanging, which is the most common suicide lethal means in Hawaii. The trauma system does not include the suicides that happen at home. The quality of data matters greatly. So in addition to safeguarding the quality, accuracy, and continuity of data, holding agencies that manage the Hawaii Violent Death Reporting System to their account, to their decisions and actions is essential. And that is why I am supporting this bill. Thank you, the chairman, the vice chair, and the committee members for this opportunity.
That's all the testifiers I have listed. Anyone else wishing to testify on this bill? Seeing none, members' questions? Chair Martin.
For Mr. Hall, please. So your testimony is very clear in the feeling that you folks already have a system like this. And yet we've heard from our other testifiers that there's some data that might be very important to suicide that you don't collect, like method, circumstance of death, location, and population risk factors. Is that something that could be added to your system so that we don't have two redundant systems?
Yes, thank you for asking. So we've issued and we have a contractor that's integrating every data point that's within the CDC system. We're in communication with the CDC so that we can integrate ours with theirs where it will electronic. So I just want to clarify, every violent death CDC data dictionary data point is being incorporated within the state patient registry system so that we will maintain control of that and can forward the information to the CDC. We did have to issue a contract and hire a contractor to assist us with that, and they're currently doing that work as we speak.
Okay, so I that addresses continuity, which I think they brought up, but what I don't know, and maybe you do know, is whether that data includes the things that they mentioned that are not being, like whether it's an event that happens at home or what is it ligature or those items. Are they already available? And if not, can they be added by our state, or do we need a separate system in order to capture that?
Do not need a separate system. We can capture that with our current capabilities, and we're implementing that right now.
Thank you, Chair.
Okay. If I could follow up with Mr. Hall, how imminent is the work of the contractor? I mean, when will you relaunch the whole system?
Yeah, so there's a couple of parts of that, right, that caused us that had the pause. One was we lost the federal funds and it was a grant, and so until we could renegotiate the terms. We've reestablished that. But in the interim, we did identify trauma and other specific funds within the Department of Health that allowed us to go out to bid to get this integrated while we were negotiating with the CDC. So we do plan in the next 6 months, but ongoing, we do have staff members supplementing, and I got a report from the CDC as of yesterday that we do have over 250 records that were concurrently that are put in the system that we're going to maintain in their system while we're building out our current system. So we're working through it. We don't have the funds to staff those people that are doing the concurrent work until we finish our terms and agreements with the CDC, and we're almost there. It's in the final review of them executing the NOA. Once we get that, we can then put out another bid for contract staff to actually do concurrent abstraction. But our current staff is doing what we can simultaneously while we're doing this work.
Okay, thank you. Next bill, if there are no other questions. Next bill we have up is HB 1669, requiring the Department of Health to provide educational materials relating to lung cancer screening. Department of Health.
Good morning, Chair Takayama and Vice Chair Leloy and members of the committee. I'm Lola Irvin, representing the Department of Health. So the Department of Health respectfully opposes HB 1669. We support promoting health and improving quality and years of life through effective prevention, detection, and management of chronic diseases. So effective is an important word here. Now what we do is rely on evidence-based strategies and collaborations to build the systems of care. And we do not find that there's any evidence that using the tobacco retail environment is an appropriate venue for educating people about lung cancer screening. Lung cancer screening is really complex in terms of when people qualify and whether they qualify, and it really should require a conversation with their healthcare provider. And also that this would be a mandate for tobacco retailers, and we find that this would be unenforceable. And it would take away resources that we have from evidence-based approaches to help people to quit, and also then to work with providers and collaborate on building the systems approach for early lung cancer screening. So thank you for the opportunity to provide testimony.
Thank you. On Zoom, I believe we have the Attorney General's office. In person.
Morning, Chair, Vice Chair, members of the committee. Blair Goto on behalf of the Department of the Attorney General. Our concern with this bill is a requirement on page 3 that every retail tobacco seller display government-designed signs at point of sale and distribute written notice about lung cancer screening to consumers. Because the signs and the notice do not directly warn consumers about the product itself, the compelled speech required by the bill could be subject to challenge under the First Amendment. Accordingly, we are recommending changing the mandatory requirements to voluntary provisions as stated in our written testimony, and I am available for questions.
Thank you. Thank you. All important shall to me. Let's see, we have testimony from the Hawaii Medical Association in support, as well as the American Lung Cancer Screening Initiative. Anyone else wishing to testify? If not, members, questions? Seeing none, let's move on. House Bill 2314 relating to emergency medical services statutes. And first up, we have, let's see, University of Hawaii in support. Hawaii Emergency Management Agency in support. Department of Health.
Thank you, Chair, Vice Chair, committee members. Garrett Hall, Chief of Emergency Medical Services and Injury Prevention. We stand on our written testimony and are in strong support of this measure introduced as part of the governor's package. We also recognize the University of Hawaii's comments and would like to provide some additional clarification. This modernization brings us up to state with, brings our state into compliance with national standards. Currently, The licensing department within the Department of Health is licensing advanced EMTs. We have 38 licensed in the state. However, our EMS statutes do not allow for us to write protocols or guidelines for those individuals that are getting licensed. So we do need that part. It does not mandate that we implement an advanced EMT program in the state. So we just want that to be clear. However, we do support the university and believe through rural healthcare transformation and the need for workforce development that advanced EMTs is something that we should pursue with the university and potentially need additional funding for them to implement those programs in the future. Mahalo and thank you. Open to any questions.
Thank you, Mr. Holmes. Let's see, Hawaii Health Planning and Development Agency, Dr. Jacqueline.
Good morning, Chair, Vice Chair, and members again. SHPTA sits on the Emergency Medical Services Advisory Council. We believe this is extremely important for us to modernize our systems throughout the whole spectrum of emergency care. We strongly support it. And I might just add as a matter of personal request is that I have a conflict. We also support the air ambulance bill that will be coming up in a few minutes. We didn't submit testimony, but that's also very much needed. Thank you very much.
Okay. Let's see, we have testimony and support from the Oahu EMS branch as well as Office of Hawaiian Affairs and Kauai County EMS. Anyone else wishing to testify on this bill, HB 2314? Seeing none, members, questions? Seeing none.
Karen Boyer on behalf of the University of Hawaii system. We stand on our written testimony with comments.
Okay, thank you. Oh, I thought I called UH, sorry. There being no questions, let's move.
I have a question.
Go ahead.
For UH. So it seems like your testimony is a funding. You was responding to, I don't know if it's for a different bill, but this is just updating the language. It's a no money bill. And so was there some confusion? Were you looking at implementing and upgrading the system?
Yes, based on the other bill, SB 3134, that provided for provisions for the EMTA license. We anticipated that we would need to provide that education to the existing community to upgrade EMT education and practicability.
Okay, thank you. Thank you, Chair.
Thank you.
If I may, Chair.
Representative Amano.
Thank you, Chair. Question for UH. Thank you for being here to testify today. I'm curious, since the need is greater on the neighbor islands, is there any effort in place to expand this program to our neighbor island system?
The EMTA program?
Correct.
Our state wasn't recognizing the licensure for, or something changed. And I can't speak to that, I haven't been in my position that long. But we could do that, we could provide that education. We would need to expand our lectures, some training facilities, and this bill allows us to consider that.
Thank you. Thank you, Chair.
Sorry, I should have asked you earlier. Could you identify yourself by name and title?
I'm Karen Boyer. I'm Dean for the Health Academic Programs at Kapiolani Community College on behalf of Louis Hokoana, Interim Vice President for Community Colleges, University of Hawaii System.
Okay, thank you very much. I don't see any other questions, so let's move on to HB 2372. Authorizing registered nurses and qualified paramedics to administer medication as part of an assisted community treatment order. First up, Attorney General's Office. Here, of course.
Thank you. Good morning, Chair, Vice Chair, committee members. Ian Suter with the Department of the Attorney General providing comments. The department believes this bill can be interpreted in a manner inconsistent with procedures for assisted community treatment, which prioritizes reasonable efforts to solicit voluntary compliance before emergency or involuntary procedures are involved. To address this, we recommend inserting language that the administration of medication in the community is done with the consent of the individual. Thank you for your time. I'm available for questions.
Thank you. Hawaii State Department of Health.
Morning, Chair, Vice Chair, members of the committee. My name is Gavin Takenaka. I'm the Adult Mental Health Division Administrator here on behalf of the department. The department stands on its written testimony, providing comments. Here we have today, in case there's questions, Dr. Koyanagi, our expert on active orders, Dr. Tori Kihara for any questions on nursing, and Chief Hall is here for paramedic. Thank you.
Just for the record, I would note, Doctor, that you're asking in your testimony for basically a more clear definition of paramedics.
Correct.
Okay, thank you.
Thank you.
Let's see. James Ireland, State and County of Honolulu, Emergency Services Department.
Chair, members, James Ireland, Director, Honolulu Emergency Services Department. We stand by our written testimony in support. I just wanted to give you a couple real world examples. For instance, about a week or so ago, we had a patient under ACT order, didn't want to get his shot. He had to be detained by the Honolulu Police Department. Nurse practitioner from IHS applied from last year Act 219 and MH3 to bring him to the Queens Medical Center, where they waited for a physician to see him. He got his shot, and then he was released back to the community. So that's how the process works now. Core had an individual who was a danger to himself recently. We found he also was due for his shot. So again, he was detained under the MH3 through the Core program and a licensed provider. HPD took him to Queens again, and he got his shot. So this would alleviate that necessary step of going to the hospital, especially if you're not in the downtown area, maybe Waianae or North Shore. It might be a lot easier to do this in the back of the ambulance. My only comment would be, under the current MH3 rules, the destination has to be approved by the Director of Health. So, for instance, the Behavioral Health Crisis Center in Iwilei, or maybe like Castle ER, Queens ER. And I'm not sure if we could detain somebody under an MH3 order and then give them the shot and then release them from the MH3. So that would be my only concern. We support the bill.
Okay, thank you, Mr. On Zoom, Hawaii Disability Rights Center.
Yes, good morning. Thank you, Chair Takayama. I'm Lou Erdeshek, Director of the Center. Well, yes, the Attorney General is correct. I totally interpreted it the other way because that is kind of how the bill reads. As I indicated in my testimony, it's not so much whether a nurse or an ambulance driver is capable of giving an injection. I don't have any issue with that. But under the law, under the current law, this has to be done in a hospital under strict medical supervision. And so when the bill was first introduced, rather when the program was created and over the years, that was always the promise that was made. So my concern initially with the bill is that the language is so open-ended that, okay, where exactly are we talking about that somebody is going to be taken to give this? So we were opposed to the bill. With the Attorney General's amendment, if the person consents, then I certainly feel better about it. I mean, if the person is willing to consent to getting the injection somewhere else, I think that's fine. Although I do have the concern that if they don't consent, they're going to get hauled off to the hospital. So I think we want to take steps to make sure that the consent is real consent and not some sort of illusory consent. I think we need to build in some safeguards. And I'm sympathetic to what Dr. Ireland is saying, but this is not supposed to be for the convenience of the ambulance driver. This is supposed to be for the protection of the patient. And so I think the current law is fine, but if the patient wants to consent to get the injection in another setting, I think that would be okay as long as we're sure that it's a genuine consent.
Okay, thank you very much for your testimony. Let's see, on Zoom, I believe we have Angelo Young. Not present? Not present here. Jim Gottstein, Stein. In opposition. Let's see, we have written testimony from the Institute for Human Services, IHS, in opposition. Anyone I missed wishing to testify on this bill? Yes, please step forward.
Good morning. I hadn't anticipated saying anything, but when I saw Dr. Island stand up here, I want you all to know that he saved my life.
Would you tell us who you are, please?
My name is Robert Pickering. I live here half-time and in Phoenix. I was doing an ocean swim for Duke Fest 13 years ago. I was out about 3/4 of a mile and I had a cardiac arrest. And the reason I didn't drown is because when you have a cardiac arrest, your heart stops. And therefore, seawater can't get into your lungs. On that day, I believe one of the very first times there was an ambulance on Kalakaua. Beach Boys got my heart going. They wheeled me right out to the street, into an ambulance, to Straub Hospital. About 70 minutes later, I was coming out of the operating room with a stent, and here I am today. Timing is critical to save lives. And I think I'm a pretty good example of that. So thank you, Doctor.
Thank you, and thank you, Mr. Pickering, for being here.
I'm delighted.
In every sense.
Well, Chair, Vice Chair, committee members, Carrie Ann Shibota, I'm a community member, and I'm here to raise concerns. They've been ongoing concern about the assisted community treatment order. As you know, I previously worked for the ACL of Hawaii as the policy director. I'm an attorney, and we have raised in the past, and I will continue to raise concerns in my personal capacity, that the fact that we do not guarantee individuals the right to legal counsel in a family court hearing relating to assisted community treatment order is unconstitutional. Not only is that my opinion, or the opinion of the ACLU previously, but the Attorney General's office some years ago also raised constitutional concerns. And just because we've since passed the law doesn't mean that we should just move on. A violation is a violation, and I know all of you are here because you care about our community, but you also take an oath to uphold the Constitution. So I ask that you consider that. The second point I want to make is that I'm very concerned about the expansion of who is able to administer psychotropic medications. There are some individuals who go to school and specialize, 12 years, fellowships, but we are expanding individuals who can literally forcibly inject people on the street who may not have capacity or may have capacity in that moment that they don't want to take that medication. Maybe there's severe side effects, there could be complications. To what extent are we going to allow a number of health professionals who are not trained to do enforced injectables? And with this idea of consent, what is truly consent? Because if you're having police coming into a place and they are armed officers, does that person really feel like they have the ability to make a decision about their bodily autonomy, the right to liberty? And so I humbly ask that you carefully consider this measure. I think there are not enough safeguards in place, and we need to rectify the fact that if individuals have due process in a family court proceeding and they're entitled to legal counsel like almost every other jurisdiction in the US, and in California, an individual is entitled to guaranteed legal counsel at every step of that process. Until we do that, I ask that you oppose this measure. Thank you.
Thank you very much. Anyone else wishing to testify? If not, members, questions?
Question. Oh, go ahead.
Representative Martin, followed by Representative Tucker.
For Dr. Ireland, please. So as we heard, seemed unrelated to this bill, but did make the point that being in close proximity is very helpful. I personally do defer to our healthcare providers over our lawyers when it comes to mental health care. And so I'm very much in support of ACT and feel that we very underutilize it in our state. And just for those who might not know, What we're discussing today is not a decision about whether to administer the treatment or not. It's just that decision has already been made through the court system with trained medical professionals. This is just about, providing the medicine that has already been court ordered. And so my question to you is, if this bill were amended as proposed by the Attorney General, that the subject has consent at that time for that particular injection, would that be helpful? Would that change anything and allow the core team that's already doing medical outreach on the street with our homeless population, would it allow them to treat more people? Or is it always the case that it's that patients object and they need to go through the police, et cetera, and be taken to the emergency room to be injected and then released?
Yeah, thank you. Just to clarify, if someone is you're right, this is a court-ordered process, the legal process has already happened, and now they're subject to this order. If someone will take the shot voluntarily, I don't think there's any issue. Core's not involved. Whoever their case manager is provides that shot for them. It can be really anywhere, wherever they're living, in a homeless shelter. So I really don't think if it's voluntary, this applies. This is for someone who skips their shot or is not complying with the court order and then has to be basically forced to take the shot. So I think that's what we're talking about here. Requires a detainment, and with respect, it doesn't inconvenience the paramedics, because generally this is handled by the police department, who transports to the emergency room, gets the shot, and then releases the patient. So we're actually not involved in this on a regular basis, but it's just we were involved last week because we happened to be detaining somebody under an MH3 because they were a danger to themselves, and just found out coincidentally they had missed their shot and needed it. So that patient was transported by Core to Queens Medical Center, where their case manager met them and gave them the shot. But I think, again, this I think just applies to those who are not following the court order, which has already gone through. But again, if they are getting this voluntarily, we wouldn't even really be involved.
As a follow-up, when you say that person was a danger to themselves, if they had had their shot, would they have likely been a danger to themselves, or they have been okay?
Hard to say.
Thank you, Chair.
I have a question for Department of Health and the testimony you provided, please. Or maybe for Dr. Chinag, it's kind of a process question, I guess. Thank you for the robust testimony, kind of outlining things like, creating the medical treatment teams for care, because, as ACLU and others have pointed out, for Department of Health. We under the ACT program, we do kind of put together these medical teams because, as ACLU and others have pointed out, we don't want to necessarily take people's rights away. We're trying to give treatment. And then, including making sure all the points you guys made about the appropriate scope of practice. So to the point that you guys kind of shared about the mobile pharmacist, is this maybe just a process thing that we're trying to do? And should the mobile pharmacist just be kind of rolled into the process a little bit more to kind of address the concerns you guys raised about who's administering and where? Would that be more appropriate and be a way to help kind of bridge some of these gaps that I think is the concerns of the bill?
Chad Coinelli, Department of Health. So what we're trying to paint a picture of in the testimony is that ACT is a very specific, intensive law that allows people with severe mental illness to be proven in court to meet the criteria of ACT. And it is the expectation of the court and the treatment program that they have a well-integrated, coordinated system whereby folks can continue to be offered psychiatric care and case management, and offered the opportunities to make choices when possible. Mobile pharmacy is a tool that is often used by some of the case management agencies that administer ACT orders. They're well-trained people who are well-versed in psychiatric medication, side effects, positive effects. For for example, with IHS, they have a close relationship with 5 Minute Pharmacy and have some of the patients who are on ACT orders be given their shots by mobile pharmacists in conjunction with coordination of the behavioral health team. Other instances that psychiatrists will go out into the field and attempt to offer the shot in a voluntary way, non-coercive way. When things play out, of course, in the days leading up to the time when the shot has to be given to the patient, there's lots of opportunities for ongoing efforts to engage the patient, convince them to stay on their medication. When the day plays out where the team goes out and has to think of all the options to all the ways that things may transpire that day, it's important that the prescriber be involved with the interaction with the patient and or the mobile pharmacist who is working as part of the treatment team be allowed to engage the patient. They may have to address patient's concerns about side effects and maybe actual side effects that need to be addressed and alternative medications may be considered. So because of all these complex moving parts, that it's helpful that the team itself and or additional team partners like 5 Minute Pharmacy or mobile pharmacists can work with the team to address that delicate situation with lots of complexities. So, sorry, it was a complex answer.
Yeah, no, I know it's a complex program, so, okay. Because then if we, okay. I think that answers my question. Okay, thank you, Chair.
Okay, thank you. Any other questions?
Sorry, Chair, I have.
Representative.
You can say Dr. Koyanagi. Thank you. Okay, so I'm trying to understand the need for this bill, and based on what you just shared and from what I've heard from other testimony, it sounds like this population that this bill is supposed to benefit, they've already been court ordered to involuntarily get medication through the process that was described. So from what I'm understanding, we know that they're taking medication, and at some point it gets to where they're not taking their medication and they become a danger either to themselves or to others. And so emergency responders appear on the scene. Typically, from what I understand, it's going to be police officers. Am I kind of following it?
In an ideal world, in most of the circumstances, it's the treatment team that should be there first. The first responders only arrive in certain circumstances, like the individual mentioned that IHS was having a very difficult time trying to find because he's bouncing all over the community. And so, in an ideal world, the team should be planning engagement in the community and having first responders respond should be the exception rather than the norm.
Okay, I follow that. So I'm assuming that this law is necessary because we don't live in an ideal world and we do end up in situations where they need to take medication without consent. But from what I'm getting is the concern is where it's going to be administered and how quickly, because currently what's required is they be taken to an approved facility, right? And so I'm hearing the concern by the AGs. It's, well, where are they going to be admitted? Where will the medication be administered in the community? And so I'm confused as to why can't we, what's wrong with the current, is it just because it's not as urgent and timely? Because if a nurse is not already with the police responding, it's gonna take time for them to get to the scene. So, I truly wanna understand the benefit of this and weighing the rights of the patient as well.
So current law basically says that providers in the field cannot administer medication when patients are not voluntarily complying. You have to go to emergency room or hospital, and that's many reasons. And including safety, patient privacy. I don't think you wanna have people getting held down on the sidewalk to get shots involuntarily. It's not a good look.
Okay, so it sounds like it's just so they can stabilize a patient versus taking them to the hospital.
So for the most part, yes. There are times when people are overdue for their ACT orders, and the other part of the law requires if the person is uncooperative with taking a shot in the community and it has come into the attention of first responders, then they probably should be taken to an emergency room. And the other part of the law is that the healthcare facility is required to determine whether the person on the ACT order is also deemed appropriate for involuntary psychiatric hospitalization.
Okay, thank you.
Thank you. Any, oh.
Yeah, for Dr. Koyanagi, thank you for being here. So, I feel like there's some overlap between the state programs and the city programs to try to address our shared problem with a lot of, pretty serious mental health, people suffering from mental health problems that are living on our streets. And what I'm hearing from you is that, you have a team that goes out and tries to, even though these are court-ordered treatments, try to work with the patient to get voluntary consent for a particular dose. And do you feel like the core team, which is also out on the street and are also, medical professionals that do have an ambulance with them, so it would not be holding down someone on the sidewalk? Do they fit in this puzzle as part of the outreach healthcare team, or do you view them as irrelevant to our state's goals of getting these people on treatment?
I think the current behavioral health case management teams are doing the best they can to work with ACT patients, and in recent years trying to understand some of the confusion or ambiguity regarding the law as far as involuntary transport. I think if a need came up in the future, the case management agency would ask for it, but I believe the court makes them responsible for providing all aspects of the care related to the ACT order, and that includes engaging the patient, giving them choices, and when, if necessary, providing them involuntary medications consistent with current laws.
So I would take that to mean that no, you do not see a role for the core program.
I don't think the current agencies I've never heard of an agency asking for an additional component of the treatment team.
Maybe if I could follow up on that, Dr. Seems like the nut of the issue is whether someone who is the subject of an ACT order needs to be taken to a hospital medical setting, or whether the whatever medication is involved can be administered by paramedics or in an ambulance. And you're saying that's not a good idea.
Like Dr. Ireland said, if the patient is willing to take medication voluntarily in the community, either the team assigned to take care of that patient can give it.
That's not what this bill says. This bill doesn't say voluntarily.
Then again, the current law specifies that patients on ACT orders need to be taken to an ER or acute care hospital for shots.
And an ambulance is not an appropriate setting.
It's not. An ambulance is not a emergency room or a hospital.
Okay. All right. Thank you very much.
But just one last question. But if that patient consented, you could give that same medication just on the street. not even in an ambulance. But somehow lacking consent means the same patient with the same medication suddenly needs our emergency rooms?
Sorry, repeat the question.
If that patient had consented, your team could give that same medication on the street, but lack of consent means they need to have an emergency room setting instead?
A person who was cooperative with taking a shot could be given that shot in the community.
Okay, thank you.
Thank you. No other questions? Let's move on to the next question.
Thank you, Chair. The time now is 10:26. I'm gonna assume role of the chair. Moving on to House Bill 2508, establishing a statewide air medical service program within the Department of Health. Members, we have Department of Health in support.
Vice Chair, Chair, committee members, Garrett Hall, State Chief of Emergency Medical Services and Injury Prevention. We stand on our written testimony in support of the Senate Concurrent Resolution 86 Working Group and this measure.
Thank you. Members on Zoom, we have Aloha Care, right? Not present. Members, we also have in support State Department of Health, Hawaii Emergency Management Agency, Hawaii Medical Association, and one individual. Anyone wishing to testify on House Bill 2508 here in the audience on Zoom? Members, any questions? Great, thank you. Moving on, members, we are on House Bill 1966 relating to amend the Emergency Medical Service Special Fund by authorizing the deposit of revenues from billable emergency medical services. Department of Health in support.
Madam Vice Chair, committee members, thank you for the opportunity to submit. We stand on our written testimony, but would also like to add a point of clarification. So thank you for the opportunity to provide this testimony in support of House Bill 1966. The proposed procurement exemption within the EMS Medical Services Special Fund, we would like to stand on our written testimony and the additional verbal comments as this measure is written to prevent delays in life-saving care that needs to be provided each day across the state. Running the statewide emergency medical services 911 system is very different than operating normal state operations each day. It's focused on providing timely, efficient, effective, equitable, patient-centered care. We would first like to respectfully acknowledge and appreciate the Procurement Office Administrator and their comments on transparency, accountability, and guidance. We share those values and ensure fair processes in preventing favoritism, collusion, fraud. It is important to note that we have submitted this comments on this measure, and it's been proven within the Department of Health through the State Trauma System Fund over the last 20 years. The Trauma System Fund has operated with a procurement exemption. During that time, the fund has allowed and demonstrated administrative oversight, transparency, and physical measures with no fraud, waste, or abuse. That flexibility allowed the state trauma system to develop where Queens became a level 1 trauma center. All of our level 3 centers are ACS verified, and we could quickly provide the equipment and life-saving care that they needed. That same is not extended to our Emergency Medical Services Special Fund. We have missed out on opportunities where ambulances could not be provided timely. Currently, we have a stroke program going across the state that's been a pilot where we're not able to quickly expand that program that's proven to save lives. We can't purchase AEDs or other items on bulk quantities which save lives due to issues with the procurement process and time limits. So we do respectfully acknowledge that that is a valid concern, but we've been doing it for the past 20 years with the Trauma System Fund with no violations. So mahalo.
On Zoom, Tom Yamachika, Tax Foundation.
Aloha, Pauline Taramai for Tom Yamachika. The Tax Foundation of Hawaii stands on its written testimony. Thank you.
Thank you. And Department of Health in Support, QuiteCom. Anyone in the audience wishing to testify? Any members on Zoom? Please proceed.
Hello, my name is Laura Mallory Sarah, and I am speaking to you as a community member, but also as the executive director of the Daniel R. Sarah Memorial Foundation. Our mission is to save lives in Hawaii, and we concur with Paul's testimony. The procurement process when it comes to emergency supplies is it's onerous. And it can take up to 2 years to purchase equipment that could be saving lives today. Oftentimes, the procurement process doesn't even provide our EMS services with the best equipment available or with the best technology available. And by the time we get it ordered through the procurement process, the cost of purchasing those items has escalated, which limits the amount of equipment that we can actually buy. I know this for a fact after serving for 28 years in purchasing emergency medical equipment for our first responders. So I would urge you to support this bill and to please allow the Department of Health not to have to go through the procurement process. I understand the valid reasons for having a procurement process in the state and the county, but this is going to be an enormous roadblock for our future. So mahalo for your time. Thank you.
Thank you, Ms. Sayer. Good to see you.
Good to see you.
All right. Thank you, members. Any questions? Great. With our chair back, I'll turn it back over to him.
Thank you, Vice Chair. Let's see, last two bills on the agenda. First up is HB 2558 relating to telehealth, expanding telehealth services to certain medical treatments out of state. First up, we have University of Hawaii.
Good morning, Chair, Vice Chair, and members of the committee. My name is Christine Bowley. I'm the UH System Director of Workforce Development. We stand on our written testimony, and I am available to answer any questions.
Thank you. BCCA.
First, we apologize for the late testimony. We have a brand new LAS coordinator. There was some mix up. So thank you for taking in our testimony. We submit some concerns relating to this bill. So I'm available for questions.
Thank you. HMSA.
Good morning, Chair Takayama, Vice Chair Keiko Hauptu-Leloy, and members of the committee. I'm Wani Ray-Fenos with HMSA. Thank you for the opportunity to provide comments on House Bill 2258. HMSA has long supported telehealth as an important tool to expand access to care, especially those living on our neighbor islands and in our rural communities. However, as access is expanded, it is critical that patient safety, quality, and accountability remain intact. Our concern really is that by allowing out-of-state providers to provide treatment to patients in Hawaii without having a Hawaii medical license permits them to function under their own home state's licensure requirements, which differ than Hawaii's, including scope of practice, prescribing rights, overall quality oversight. I'd also like to point out additionally that in the bill, there's language that states that this shall only apply to services with physician shortages or lack of reasonable access, which is very broad and undefined and could cause some confusion and overall inconsistent application. So thank you for your time this morning. I'm available for questions.
Thank you. Let's see, we have Aloha Care offering support on Zoom. Hawaii Islands Republican Women. Jamie Detweiler.
Aloha Chair, can you hear me?
Yes, we can.
Aloha Chair Takayama, Vice Chair Kyoho Kapuliloi, and members of the committee, Jamie Detweiler, Hawaiian Islands Republican Women, testifying in strong support of HB 2558 for the following reasons. Allowing Hawaii residents to access telehealth care from qualifying out-of-state providers could help address healthcare access and staffing shortages, especially in rural and underserved areas. Specialty care providers are highly sought after, which often leads to longer wait times and postponed treatment. I'd like to also bring in a personal note. I know of two family members who reside on Hawaii Island, where it is even harder to access specialty care. And they have experienced postponed or delayed treatment. And so, for these reasons, Chair, Vice Chair, and members of the committee, please vote yes on HB 2558. Mahalo for the opportunity to testify.
Thank you. Let's see, we have a Healthcare Association of Hawaii, Paige Choi offering comments. Hawaii Association of Professional Nurses in opposition. Grassroots Institute of Hawaii in support. Hawaii Medical Association in offering comments. So we have written testimony from 14 individuals in support and 1 in opposition. Anyone else wanting to testify on this bill?
Aloha Chair, Vice Chair, Committee members, Carrie Ann Shirota. I'm living in Honolulu but was raised in Kapakalo on the island of Maui, which is a very rural area. And I can speak that my family members consistently have difficulties accessing care. Constant turnover of PCPs, lack of access to specialists. Sometimes they're able to travel here to Oahu, but other times that has not been possible. And I can just share with you, even though I looked at the bill quickly, I would need more time to vet it. I would really like to see that this concept further explored because of the fact there is a critical shortage. And I'll give you 2 examples. About 2.5 years ago, my loved one was diagnosed with a rare cancer. Very few oncologists here were familiar with it. Despite severe pain the person was going through, we had to fly up to California to the City of Hope, pushing him in a wheelchair to be seen for a consultation. Because we did not allow for telehealth, we literally needed to find the resources to get up there, and it was just so difficult to see this person already suffering, to put him on a plane, who had lesions on his spinal cord. If we allow for the specialist to work, that could have possibly alleviated or reduced the number of times for a bone marrow transplant surgery further down the line. And currently I have another family member who lives on Maui, and she's been diagnosed with a rare condition. And we literally this week, I've been calling UCLA, Stanford, other specialists to see if we can get additional care or second opinion. And a number of these places allow for second opinion, sometimes a written second opinion, but they will take a look at the state. If they don't have a doctor who's dual licensed in Hawaii and California, they're saying, we can't see your sister. Which probably shouldn't have said that. See a family member by telehealth because we're afraid that we're gonna be charged with unauthorized practice of medicine. But this is a serious condition, and I just humbly ask that you think about people on the neighbor islands, for all of us who need a specialist. Thank you.
Thank you. Anyone else wishing to testify? If not, members, questions? I have a question for DCCA. I read your testimony to say that you have concerns about out-of-state physicians practically practicing medicine via telehealth, and that this would limit, number one, knowing what their qualifications are, and your being able to know if they have any background negativity in their records. Would it alleviate state's concerns if we made it clear that the telehealth practitioner must be under the supervision of an in-state physician here in Hawaii?
Yes. Where we are processing application, at least 30% has convictions or disciplinary the action relate to malpractice. So Hawaii Medical Board and the RICO, we work together to appropriate suspension or any kind of filing of action. But when we just allow out-of-state physician come to here without any types of license here, Hawaii has no jurisdiction to control them. So we only think about only good doctors come here, but always there's some bad ones come together. So when some accident, incident, malpractice that happen, when they disappear, and it is totally patients and get more harm from that.
Okay, thank you very much. There being no other questions, let's move on to the final bill on the agenda. House Bill 1898 regarding immunization. First up, we have, let's see. The Attorney, Deputy Attorney General.
Good morning, Chair, Vice Chair, and members of the committee. My name is Kaina Kia, and I am here on behalf of the Department of the Attorney General to provide the following comments on possible points of confusion with implementation of this bill. We note that department is not defined as Department of Health. We also note that the bill changes prevailing medical standards, plural, to prevailing medical standards, singular. And we also note that it uses a clear and convincing evidentiary standard, which is a legal standard that's not easily translated into a non-legal setting. As such, we provided recommendations prescribed in our written testimony to avoid any possible confusion when implementing the bill. I am available for any questions. Thank you for the opportunity to provide comments.
Thank you. Department of Health.
Aloha, Chair, Vice Chair, and community members. I'm Kenny Fink with the Department of Health, providing comments. We very much appreciate the intent of this bill that seeks to address a very important public health issue. Under the Patient Protection and Affordable Care Act, health plans were required to cover evidence-based preventive services recommended by the Advisory Committee on Immunization Practices and the U.S. Preventive Services Task Force. In the past year, there have been changes that have negatively impacted that. The U.S. Preventive Services Task Force has not met since March of last year, and for the ACIP, after its membership was replaced, it has stopped following a process by which it looks at the full body of evidence in a systematic and transparent way, and it has not adopted a evidence recommendation framework. That has resulted in a divergence of its recommendations from those of the American Academy of Pediatrics. Those two different sets of recommendations or standards are in conflict, and as was raised, having one set standard of both creates confusion to providers and to patients and perhaps to the coverage. So we acknowledge those remarks. We also feel that it is important to have one single set of recommendations for clarity for patients and providers and to ensure coverage without cost sharing for such recommendations. To ensure access to care is a priority, and to follow the intent of what was initially passed to allow coverage to these important preventive services. So rather than having a federally mandated process, we are proposing to have a state-based process that is provider-led. So there is a single set of recommendations for the state that health plans would cover, again, to follow the intent of the essential benefit services. In addition, the goal is to ensure access for those who choose to receive these preventive services. So ensuring that pharmacists can continue to provide such recommendations is important, as that may be the access to care for many people, particularly in rural areas. In addition, we want to protect providers who are following these recommendations from a local group. So with respect to the introducer of the bill, we hope that these are received as friendly amendments to advance the intent of the measure and we do offer amendments for your consideration. All of your time.
Thank you. See, DCCA?
Good morning, Chair, Vice Chair, members of the committees. Justin Chu for the BCCA's Insurance Division. We stand at our written testimony providing comments and available for questions.
Okay. HMSA?
Chair, Vice Chair, members of the committee, welcome to HMSA. HMSA recognizes the challenges and uncertainty created by the constantly shifting federal landscape regarding healthcare policy. As a healthcare organization, our commitment to our members and the state has led us to expand our immunization policies to include recommendations beyond the ACIP, including but not limited to guidance from the Department of Health and the American Academy of Pediatrics. I think our comments largely surround around the fact that we're not certain how conflicting guidance from the two organizations listed within the bill can both be presumed to be the standard by the department. We highly agree with Department of Health that vaccinations improve health outcomes and want to ensure that individuals who choose to be vaccinated continue to have reliable access to coverage. Thank you for the opportunity to testify.
Thank you. So we have written comments written comments from the Hawaii Medical Association, Healthcare Association of Hawaii, comments from HEP3 Hawaii, and written testimony from 2 individuals in support and 2 opposed. Anyone else wishing to testify on HB 1898? Members, any questions? Representative?
Thank you, Chair. For DCCA, please. I'm reading here your testimony on, I think it's on page 1, it says the department notes that it is unclear whether the amendments in section 2 through 4 of the bill would trigger the frail requirements under 45 Code of Federal Regulations. Could you please elaborate on that?
Sure. I guess I'll start from the top, which is that under the Affordable Care Act, every insurance plan sold in the state is required to meet or exceed what's called the Essential Health Benefits Plan. And because these plans are subsidized on the federal exchange, if the state mandates benefits that go beyond that, the state is required to defray the cost of those benefits for those plans sold on the exchange. So as part of that, part of the Essential Health Benefits Plan are required to cover recommendations by the HST, the Advisory Committee. So so granting these powers to the Department of Health, if the Department of Health decides to mandate immunizations that are not currently covered in the Essential Health Benefits Plan, are not currently recommended by ACIP, which sounds like possibly could be the case, and the state might be on the hook for defraying those costs.
Got it, thank you.
Sure.
Any other questions from members? If not, let's move on to decision making. Thank you to all the testifiers for taking time to let us hear from you. I really appreciate it. First up, we have House Bill 1871, establishing a maternal health monitoring pilot program. I'd like to suggest we move this forward as a House draft, making a couple of amendments. On page 2 of the bill, lines 9 and 10, we want to make it clear that people covered in this bill are both nurses and dietitians who are licensed in Hawaii. Secondly, that since there's no end date for this bill, we want to make it clear that, sorry, bear with me. So we'll put in language on page 4, subsection F, that says the pilot program shall conclude 2 years after the pilot program becomes operational, or no later than December 27th, 1929, whichever occurs first. Also, we'd like to remove the $600,000 that's mentioned in the bill and move that to report language. Also, make some technical amendments for clarification and consistency in style and also added. Members, any questions, comments, or concerns? If not, Vice Chair for the vote.
Thank you, Chair. Members, voting on House Bill 1871, Chair's recommendation is to pass with amendments. Chair votes aye, Vice Chair votes aye. Member Amato.
Aye.
Member Hartsfield.
Aye.
Member Martin.
Aye.
Member Olds.
Aye.
Member Takanouchi.
Aye.
Member Alcos.
Aye.
Member Garcia.
Aye.
Thank you, members. Chair, your recommendation is adopted.
Thank you. HB 1977, maternal and infant mobile app. I'd like to move this forward with a couple amendments. First of all, there's a blank starting date. We'll put in, on page 1, we'll put in January 1st, 2027 as a start date. Secondly, making it clear that under the rules section of the bill, that the Department of Health shall determine the number of participants in the program. Third is require a report to the 2029 legislature, filling in that blank as well. Fourth, blanking out the $150,000 and moving that to report language. Also defecting the date and other technical amendments. Questions, comments, concerns? Vice Chair for the vote.
Thank you, Chair. Members, voting on House Bill 1977, Chair's recommendation is to pass with amendments, noting all members present. Any members voting with reservations? Any members voting no? Chair, your recommendation is adopted.
Thank you. The next bill is HB 1878 relating to fetal death. I'd like to
1858?
yeah, is that what I said?
I thought I heard 70, but
Oh, I'm sorry.
I could be wrong.
I'll articulate more clearly. HB 1858 relating to fetal deaths. I'd like to move this forward as a House draft. Noting that on page 6 of the bill, we would like to replace the existing lines 4 through 15, and this relates to certificates for fetal deaths for miscarriages less than 20 weeks gestation. Replace it with language that was suggested by the Department of Health as well as Dr. Vink and other OBGYNs. And I will read that section. It will say that the attending physician, physician assistant, advanced practice registered nurse, or coroner's physician who certified the fetal death due to miscarriage shall issue documentation of fetal death to a birthing parent who experienced a miscarriage upon request of the parent. And it goes on, I won't read it all, but it makes clear what the statement and certificate shall consist of, and other explanation of documentation that is required. So also like to add a defective date and other technical amendments for style and consistency. Members, any questions? If not, Vice Chair.
Thank you, Chair. Members, voting on House Bill 1858, Chair's recommendation is to pass with amendments. Noting all members present, any members with reservations? Any members voting no?
No vote. No vote.
Thank you, Mr. Alcos. Thank you, Mr. Garcia. Chair, your recommendation is adopted.
Thank you. Next bill is HB 1591 relating to a preceptor tax credit. I'd like to adopt the amendments suggested by DOTAX, mostly making clear a couple definitions as well as other suggestions. I'd like to add registered dietitians as being eligible for the tax credit. This is consistent with what we passed in a House bill last session. Also like to add technical amendments as well as defective date. Questions, comments? If not, Vice Chair.
Thank you, Chair. Members voting on House Bill 1591, Chair's recommendation is to pass with amendments, noting all members present. Any members with reservations? Any members voting no? Thank you, Chair. Your recommendation is adopted.
Thank you. Next bill, HB 1574, relating to the loan repayment program for healthcare education. I'd like to move this forward as a House draft. On page 4, adding dentists to the definition of healthcare professionals. Also making a defective date and technical amendments. Questions, comments, concerns? If not, Vice Chair.
Thank you, Chair. Members voting on House Bill 1574, Chair's recommendation is to pass with amendments, noting all members present. Any members with reservations? Any members voting no? Chair, your recommendation is adopted.
Thank you. HB 1575 relating to Parkinson's Patient Air Transport Committee. I'd like to move this forward as a House draft. I think the bill needs further work, but we want to keep the bill alive and move it on to the next committee. I'd like to remove the $100,000 from the bill and move that to report language. Also defective date and technical amendments. Questions, comments, concerns? Vice Chair for the vote.
Thank you, Chair. Members, House Bill 1575, Chair's recommendation is to pass with amendments, noting all members present. Any members with reservation? Any members voting no? Chair, your recommendation is adopted.
Thank you. HB 1854 relating to community behavior health clinics. I'd like to move this forward with a couple amendments. On page 2 and 3, make it clear that the DOH certification process must meet the standards of the U.S. Substance Abuse and Mental Health Services Administration, also known as SAMHSA. Delete the section that would create a special fund. Delete the $800,000 from the measure and put that in the report language. Also adopt the DOH amendment on page 5, line 10, changing the language from populated island to populated county. Also effective date and other technical amendments. I think that's okay. Questions, comments, concerns?
Would changing it to county mean that in another place you have to decrease the members from 11 to 9?
Oh yeah. I'm sorry, and further amendment making a commensurate correction in the number of members on the committee. Okay, Vice Chair.
Thank you, Chair. Members voting on House Bill 1854, Chair's recommendation is to pass with amendments, noting all members present. Any with reservation? Any voting no? Chair, your recommendation is adopted.
Okay, HB 1855, violent death reporting. We had much discussion on this. I'd like to encourage Colonel Swanson to work with the Department of Health in its implementing an upgrade of the violent death reporting system for us in Hawaii. I think the bill is, according to testifiers, is probably not needed at this time. We'll consider it in the future. For now, we'll defer it. HB 1669 relating to lung cancer screening. Also like to note the concerns expressed by the Attorney General and the Department of Health, so defer this bill as well. HB 2314 relating to emergency medical systems of care. I'd like to move this forward as a House draft. On page 6, with a couple amendments. On page 6, sorry, bear with me. page 6, on line, beginning on line 8 through 12, change emergency medical services personnel language to say that EMS personnel means any healthcare worker who is certified to provide emergency services. And substitute that for the language in those lines. Also, conforming amendments for consistency, clarity, and style, as well as a defective date. Thank you, members. Any questions, concerns? If not, Vice Chair.
Thank you, Chair. Members voting on House Bill 2314, Chair's recommendation is to pass with amendments noting all members present. Any members voting with reservation? Any members voting no? Chair, your recommendation is adopted.
Thank you. HB 2372 relating to assisted community treatment. We've had lots of discussion on this measure. It's a work in progress. I'd like to move this forward. I'll adopt the language suggested by the Attorney General, which makes it clear that nurses and other personnel may, with the consent of the subject of the order, administer appropriate medication, and that's on page 3, first 4 lines. Again, this is controversial, so I will note in the report language accompanying the bill, and I'll ask the Judiciary Committee to consider whether this provision is required under our HRS. Also adopt the DOH clarifying language regarding paramedics, and also defective date and technical amendments. Also making clear that the new positions that are, I'm sorry, no, that's it. That's it. So, any questions, comments, concerns?
Chair, comment. Go ahead.
Representative Amato.
Thank you, Chair. This is a complex question. I'm concerned that based on testimony that consent under duress is not really consent. I'm concerned that in a situation of forcible injection, it may be a violation of due process rights. And given that I swore an oath to uphold both the US and the state constitutions, specifically the due process rights rooted in the 14th Amendment of the US Constitution and also enshrined in Article 1, Section 5 of the Hawaii State Constitution. These rights ensure fair, non-arbitrary legal and administrative procedures for all individuals. Given the erosion of due process rights we've seen at the federal level, we have a clear responsibility at the state level to make extra efforts to preserve those rights. In order to uphold my oath of office, I must vote no.
Thank you, Representative Hartsfield.
Thank you, Chair. Similarly, that's why I had Rep. Amato go first, because she articulated it much better than I could have. But I'm gonna be voting with reservations because I do believe there needs to be further discussions. And let's see how far this bill can go, but Representative Amato clearly expressed a concern that I have as well. Thank you, Chair.
Thank you. And, go ahead, Representative.
Thank you, Chair. Similar concerns. I do believe that this is a fine balance. I mean, the problem is clearly seen in our streets and communities, so something needs to take place and happen, but the constitutional concerns is there, and I want to put that on the record, so I'll be casting a vote in support with reservations. Thank you.
Thank you. Any other questions, comments?
Yeah, I really appreciate that the discussion that was brought up by this bill, and I feel like it kind of shone a light on a problem we have in our state with our state and county not working together well to address our homeless population with severe mental health illness. And so anyways, I'm not sure where this bill will go, but I had not realized until this conversation the extent of that lapse in coordination of available services. And so that's something I'd really like to have our state work on.
Thank you, and if I might say as chair that my purpose behind what I'm recommending is to keep the bill alive, because I'm aware of the sensitive issues involved, but yet it's an important, ACTs are an important consideration in our community, noting as Representative Garcia, the prevalence of mentally ill, homeless in our streets, and the need to do something about that. So, thank you, members, for your comments. Vice Chair.
Thank you, Chair. Members, voting on House Bill 2372, Chair's recommendation is to pass with amendments, noting all members present, noting reservations from Member Hartsfield and Member Garcia. Any other members voting with reservation? Noting a no vote from Member Amato. Any other members voting no? Chair, your recommendation is adopted.
Thank you. HB 2508 relating to paramedical services, I'd like to move this forward as a House draft, making it clear that the new positions created are exempt from Chapter 76. Also technical amendments and the effective date. Questions, comments? Vice Chair.
Thank you, Chair. Members, voting on House Bill 2508, Chair's recommendation is to pass with amendments, noting all members present, any members with reservations, any members voting no. Chair, your recommendation is adopted.
Okay, next bill is HB 1966 relating to emergency medical special fund. I'd like to move this forward as a House draft with technical amendments as well as a effective date. Questions, comments? Vice Chair.
Thank you, Chair. Members, voting on House Bill 1966. Chair's recommendation is to pass with amendments, noting all members present, any members with reservation.
Reservations.
Thank you, Mr. Garcia. Any members voting no? Chair, your recommendation is adopted.
Thank you. Next bill, HB 2558. I'd like to move this forward as a House draft, adding language to require that telehealth services must be supervised by a licensed in-state physician. Also, on page 9 of the bill, subsection D, on lines 20 to 21, delete that because it refers to a violation of state laws that are really not relevant here. Also added effective date and technical amendments. Questions, comments, concerns? Vice Chair.
Thank you, Chair. Members, voting on House Bill 2558, Chair's recommendation is to pass with amendments, noting all members present, any members with reservation, any members voting no. Chair, your recommendation is adopted.
Thank you. The final bill, HB 1898, relating to immunizations. I've received a request from the chair of the House Consumer Protection Committee. He has asked me to move this bill forward, but because he's in current discussions with the Department of Health on possible amendments, at this time we won't make changes that are suggested by the DOH, but we will make an effective date on the bill. Also note that the Senate has a bill in progress, so at this time I'd like to move this forward as a House draft, simply defecting the effective date, and note that this bill is a work in progress that will be worked on in the coming rest of the session. Questions, comments, concerns? Vice Chair.
Thank you, Chair. Members, voting on House Bill 1898, Chair's recommendation is to pass with amendments, noting all members present, any members with reservations, any members voting no.
No vote.
No vote. Thank you, Mr. Garcia. Thank you, Mr. Alcos. Chair, your recommendation is adopted.
Thank you, members, for your patience. We're adjourned.